These are my disclosures, and I want to thank the organizers for inviting me to talk to you today. In the next 25 minutes, what I hope to do is really talk to you a little bit about how we're seeing oral PrEP use evolving, particularly in the African region, and then spend some time reflecting on what lessons we've learned and how we can take them and incorporate them in really scaling up PrEP in the region. And then spend a little bit of time talking about some of the future ART-based HIV prevention products that are in the pipeline. So in 2015, we were all very excited when the WHO made a recommendation that oral PrEP should be offered as part of a comprehensive HIV prevention package to be offered to people at substantial risk for HIV infection. And this recommendation was made off the back of a systematic review of up to 18 trials, both randomized placebo-controlled trials as well as open-label trials, which showed that overall, across different modes of transmission and different regimens of TDF or TDF-FTC, that they reduced HIV risk by significantly. In addition, they showed that the level of protection was strongly correlated with adherence, and trials that had adherence levels above 70% based on drug levels saw very high levels of protection. What was also important from this review is that it showed that the adverse events that were observed in the TDF-FTC arm were similar to the placebo arm, so PrEP was safe for recommendation. And as a result of this, the idea was mathematical modeling essentially informed the recommendation that PrEP be offered in populations where the risk of HIV infection was about 3% per year. And so for us in Africa, that would have involved adolescent girls and young women, key populations, and other populations like serodiscordant couples. And it would be cost effective if offered to those populations and have significant impact. So much so that in 2016, as part of the UNAIDS Global Declaration to fast-track the end of HIV, PrEP targets were added to the Prevention 2020 plan, with the goal of having 33 million people access PrEP by 2020. So with that goal in mind, how are we doing going towards our 2020 targets? And this is data that comes from PrEP Watch. It's a website that you can access. It's very useful. It's run by AVAC and the Options Consortium. And the information there tells us that since the WHO recommendation, TDF-FTC has been reviewed by about 40 regulatory authorities globally and licensed for use as PrEP, but has been included in more than 68 country programs offering PrEP. And to date, in Q1 of 2019, just under 500,000 people were on PrEP worldwide, which sounds like a great achievement. When we look at who's getting PrEP, the US takes the biggest share. About 3/4 of PrEP users live in the US, but 15% of them live in sub-Saharan Africa. And so these are really important achievements, and we should not sneeze at them at all. But they're still way below where we want to be. They're 15% of target, and we have a ways to go before we reach that 3 million. So why is it that we're struggling to achieve our PrEP targets when we have data that just reinforces that out in real-world settings, that PrEP is able to reduce HIV infection? This is data from an updated analysis of open-label demonstration projects in 46 countries, so diverse geographies, involving about 10,000 people and 10,000 person years. And over that entirety of people, there were only 91 new infections, leading to an estimated incidence in that population of less than 1%. And that's very much comparable to what was seen in the clinical trials. But what's very interesting is that about 1/3 of those infections were actually in people who'd been off PrEP for 30 days. And when they looked at, they had drug level feedback, drug levels in seroconverters, what they also saw was that about 40% of people had no detectable drug, and only 2% of people had drug levels that would have been consistent with having taken 4 doses a week, reinforcing the message that we saw from the trials that adherence really is key to PrEP effectiveness, and most infections are appearing when people have intermittent or no PrEP use. So it's important that we think about the second goal of PrEP programs. The first is obviously uptake, and we've been successful in achieving that. But what we also want to achieve for public health impact really is prevention effective adherence. And this is a notion where we want people to use PrEP at times where they have high HIV risk. This is a slightly different idea from what we see in treatment programs, and I'll talk a little bit more about why we need to shift our thinking from a treatment to a prevention framework when looking at graphs like this. But ultimately, our second goal is to ensure that during periods of exposure, people have access to prevention, including PrEP. So what are the barriers then to either uptake or to prevention effective use? And there are lessons that we have been observed in the PrEP programs which actually resonate with other programs that deal with sexual and reproductive health technologies. And what we've learned really repeatedly from the family planning field where new products have been introduced is that a sole reliance on the technology is not going to achieve the potential it promises if you don't have a health system that's capacitated and a community communities or a social context which enables uptake and use of that product. So very often new products, not just PrEP, are hampered by stigma and social barriers. So people associating these technologies, for example, with sexual promiscuity. Often there is provider bias, where the idea that you're giving people these products means that you're giving them license to have sex. And often that is coupled with a limited capacity of the health system. So the health system has limited infrastructure for distribution. Often there's little investment in provider training. And there's also limited data to really help guide programming. And so, kind of these are lessons that have been learned from contraception. That graph on the far, whichever side, that graph, is data from the South African introduction of the implant, so not PrEP, showing kind of how a product can be undermined just by poor provider training and poor health system capacity. And it's very difficult to redeem products after that. And as a result of these lessons, WHO has actually devised a product introduction framework which focuses very much on the technology, but also the services and the people who are going to either provide or receive these products. And all 3 aspects of the program need to be addressed. So 2 years ago at the South African AIDS conference in Durban, when Linda Gale actually gave a talk on the 5 PrEP controversies, and I was thinking back to that time when actually it felt like these controversies were really hampering our ability to get out of the starting blocks. We were having so many discussions about things which meant that the program wasn't advancing. And if we take a moment to reflect, it seemed like a good opportunity to take stock and say, are these controversies still a challenge to our program? And I think as we've seen demonstration projects move to national scale up in the region and have in our region alone the experience of 50,000 initiations, I think we've seen growing confidence with PrEP delivery. And I would say that we've pretty much tied up these 5 controversies. We have recommendations around pregnancy and breastfeeding, and this was particular, I think, to South Africa, but even so, we seem to be moving forward. The debates about time to protection seem to have waned, and the discussions about, kind of which data set to pay attention to have focused more on the importance of getting people to start taking PrEP. The PrEP messaging has really evolved, and it's very interesting to see national campaigns, and I'll share some of those images with you. And the concerns about risk compensation, while they may persist in some people's minds, the data that we're seeing does not support them. And finally, the concerns about cost, while they exist, we have been able to successfully negotiate generic costs for PrEP. And also kind of, I think as we begin to streamline programs, we will be able to address the costs. So some of those barriers to PrEP scale-up, I think, have been removed, creating real opportunities for us to think about what we've learned and how we can really, in the next 5 years, focus on scaling up PrEP to achieve the targets that have been set. So I think, based on the experience we've had in demonstration projects and national programs, that there are 4 areas that we should be paying attention to as we scale up PrEP: demand creation, demedicalized and streamlined delivery, integrated services, and differentiated models of adherence support. So some of what you heard Linda Gale say, I'm going to repeat. So these are images that have been used in a South African demand creation program. And the important message here is that demand creation is absolutely needed for PrEP. And even if you implement demand creation, you won't be overwhelmed. But it's incredibly important to educate potential users about PrEP, particularly in communities where there is very little knowledge of PrEP. And not just potential users, but actually also the people who support them. What we've learned from studies in adolescent girls and young women is that it's very difficult to be a committed PrEP user when all the people around you don't believe that PrEP exists or will work, and you're having to not just be a user, but also an ambassador for PrEP. And so this has been an important lesson. The other thing that's been important has been the framing. So you heard this idea of gains framing. All of these materials across PrEP programs globally have been very sex positive, very focused on empowerment for young women, very focused on intimacy and positive relationships. And this idea about sort of strengthening and having healthy relationships is very attractive to people, rather than our kind of focus on risk. The last thing is that these demand creation materials need to use multiple channels. They need to use multiple modes of communication. And this is because we've learned repeatedly that people need to hear the message more than once, and they need to hear it through multiple channels, particularly young people whose attention is being demanded of by many other things. So demand creation is really critical, both for increasing uptake, but also reducing stigma, which is a very key barrier to PrEP delivery. So the second important approach is really task shifting and demedicalized approaches. And this challenges us really to assess the framework that we've been using to deliver PrEP. Many of us who've worked in HIV treatment programs have come to HIV and antiretrovirals as something medically complicated, something that needs lifelong adherence, without breaks, and with breaks could be fatal. And now we have PrEP, which really is not for people who are ill. It's for the most part not medically complex. You don't need lifelong adherence. You can take breaks. You only need to take it during periods of risk. And it's not needed when risk is present. And those 2 frameworks, we really need to shift from the treatment framework into a prevention framework. Because if we do that, we can focus on strategies that are going to minimize time and burden. So there are approaches that are being recommended, like we are trying online information to support PrEP decision-making, so that young women don't have to go into clinics to speak to a nurse to ask about PrEP. They can get information online. They can go through a decision support tool that can help them make a decision about whether PrEP is for them, and can also help them identify where the services could be. Self-testing is another way that keeps healthy people out of clinics. Same-day PrEP starts. We've learned, I think, from these 50,000 initiations and the follow-up of people on PrEP, that the need for medical monitoring is not a prerequisite. And probably in people under the age of 35 with no comorbidities, we really can do without much monitoring apart from HIV testing. And streamlining this medical monitoring would really reduce costs, as well as the visit burden, which has costs both for the user as well as for the health service. And then we also have to reduce barriers in access through task shifting. Sorry, I'm a bit too short. I can't see my slides. So For example, many programs rely on doctors still, or they rely on NIMARC-trained nurses, but those are scarce resources. And in fact, we could really kind of increase access by making PrEP available through pharmacists, by making PrEP available through nurse-driven services. And Linda Gale also mentioned the mobile services, where we take services to people and where they're at risk, rather than relying on them coming to us. The other key thing that we have to think about when we scale up is service integration. So this is something we've heard, I think, for many years, but I think PrEP has created a real opportunity for us to rethink integration. PrEP is a sexual and reproductive health technology, and people who use PrEP are sexually active and have other sexual and reproductive health needs. So service integration is responsive to their needs. And PrEP, when it's delivered as part of a sexual and reproductive health package, can actually enhance engagement in care. Because people come for their PrEP, but you can actually also offer them contraception if you're concerned about pregnancy. You can offer screening for STIs in populations that may be at high risk for STIs. So there is the potential to provide additional services which actually may, kind of benefit that person, but also kind of provide, program efficiency and reduce cost. And also, kind of this regular engagement allows you to have discussions with the PrEP user about their ongoing HIV prevention and SRH choices in the context of changing risk, and so to offer them other alternatives which still keep them engaged in care. So these all have real benefits, both for the PrEP user but also for the health system. And ultimately, providing PrEP as part of a sexual and reproductive health service begins to create the platform that we need for other technologies, which might come either as single PrEP technologies or multipurpose technologies. And then there is also the opportunity to start to add on, as Linda Gale was mentioning, other important health services for particular groups. So for example, in South Africa, intimate partner violence is a very common problem. It has serious health consequences and we can easily add screening for gender-based violence into our HIV prevention program and have benefits both from a GBV perspective but also from an HIV prevention perspective, in that we may see benefits in terms of PrEP use. So the last thing I want to comment on is the need for differentiated models of adherence support. I don't think one size fits all. Not everyone needs everything. To recall the graph that I showed you earlier, this is a PrEP cascade from a population of adolescents in fact, on a project working with Linda Gale and Elizabeth called POWER, where we're looking at different models of PrEP delivery for adolescent girls and young women. And, kind of one of the things that we've seen across these different cascades is the, kind of the attrition at each of the steps of follow-up. And this has created concern for people. But what we have understood is that in young people, there may be multiple reasons that they're stopping to take PrEP. Some might have tried for novelty reasons. Some may not like the side effects. Some may have changing risk. And these are things we need to understand better. But when we look at those people, when we look at persistence for people who go beyond month 1, they've navigated the side effects, they've decided this is something they're going to stick with, we actually see very good persistence. And these are people who are not receiving much else in the way of adherence support. So not everyone needs the kitchen sink. And what we need to be able to do is identify those people who do need additional support. Just to kind of reinforce that idea, and the other panel is drug level data in a cohort of adolescents in Johannesburg, Cape Town, and Harare. And what we can see there are, in fact, very high levels of adherence in some of those young people. And that high adherence was associated with knowledge of sexual partners, partner serostatus, but also not having depression, disclosure of PrEP use, and attending clubs. So hinting to us that social support is really important. And if young people have social support mechanisms, they may be able to take they may be able to take PrEP use, they may be able to take PrEP very effectively with minimal support. So this is a study that we're doing in Johannesburg, which is taking the ideas from treatment and looking at whether we can apply this notion of differentiated models of care to adherence support. This study uses a smart design, and it looks at creating a stepped adherence support model, with the first layer being very light touch mobile technologies for adherence support, then using drug levels, identifying a group that have achieved a reasonable level of PrEP use, and those that haven't, randomizing them to more intensive interventions, which are either more frequent visits or drug level feedback. And hopefully this will give us insight into the population that does need more support and what the package might be. But the idea, again, is that we're aiming to streamline services and to only provide support to those people who really need it, so that we can make sure that these interventions are scalable. Okay, so in addition to these things, effective implementation also requires, I think, long-acting products. In the end, we won't be able to overcome all these adherence challenges that are associated with pill taking with these strategies, and ultimately we need additional prevention products. So what I'm going to do now is just review a few of the alternative formulations. So we'll talk a little bit about rings, then long-acting injectables, and then talk a little bit about implants, and save some of the other oral pills and other things for another day, perhaps the on-demand products for another day. So the ring is a flexible silicone vaginal ring that was developed by IPM. It's a female-controlled method of HIV prevention. It can be inserted by the user, and it's desirable because it's slightly more long-acting, so monthly. It's discreet. You can't necessarily see that someone is using it. And for those reasons, and it's topical, so there's although it releases dapivirine from the ring, there's not much systemic absorption. So this product was evaluated in 2 phase 3 trials, and in those trials, the overall estimate of risk reduction was about 30% from both trials. The trials then went on to develop open label cohorts, and so a population that was aware of the product efficacy and chose to continue using those products, when that data were analyzed, it suggested that there was even greater levels of protection, in the order of 50% in the women using the ring. So this has now been filed with the EMA and is under review, and we will hear shortly about the outcome of that regulatory review. But many people believe that this is an important additional product for people who may not want systemic products and who may want a long-acting product. Importantly, there are a couple of other studies that are underway in adolescents, pregnant and breastfeeding women to make sure that we have data on not just healthy women, but also younger populations and women who may fall pregnant. But really, when we look across a range of studies, either discrete choice experiments or surveys or kind of more real-world experience of these products, we see that there is an overwhelming interest and desire for long-acting injectable products, and this might be partly because of the familiarity of these products from contraception. So one of the molecules that is being developed as PrEP and also in treatment is an experimental molecule called Cabot Agave. It's very similar in molecular structure to dolutegravir, but not completely the same. It's an integrase inhibitor, and because of its structure, it's possible to nanomill it and create a nanosuspension, and for that reason, it's possible to formulate it as an injectable and to use it for infrequent dosing. It has a higher genetic barrier to resistance, which is also important for a long-acting product. And it comes in an oral formulation, which is also, as you'll see, quite important. So no talk about injectables would be complete without a discussion of the tail. And I want you to know that a lemur has a tail which is in excess of its body. But in fact, when I was looking at animals, giraffes are animals that have the longest tails. So but they're both African, so it was a reasonable choice. So the issue with the PK tail is that when we administer a long-acting product, it's a non-removable method. And so what we have to do is make sure that we have an oral lead-in to assess toxicity before we administer this long-acting product that can't be removed. But also, once people have the injection on board, we would be concerned if they have this prolonged subtherapeutic tail, especially if they're poorly adherent. And this graphic kind of articulates why. When you have high drug level, you can suppress virus. And when you have, kind of no drug, then kind of you don't run the risk of viral resistance. But there is a zone in that pink area where there's some drug and there may be some virus, and that virus is able to develop resistance. So this is a theoretical risk with all long-acting products. So what do we know about the tail of Cabot Agave? Well, there are two studies, two phase 2 and PK studies that have been conducted, one solely in men, and the HBTN 077 study conducted in both men and women, and in domestic US as well as international cohorts. And the bottom line is that in women more than men, and particularly in women with high BMI, the PK tail persists out beyond 76 weeks. Now, you can see that in the majority of people, they may have a level about 1 to 4 times the PAIC90, and in fact, that may be protective for those people. But there's this theoretical risk, which we will only learn more about from the trials. And so this is something that continues to be a matter of scientific investigation. What are the consequences of this PK tail? To address the tail, though, the two phase 3 studies, which have gone forward for development on the basis of these phase 2 studies, are kind of a unique design. The goal of both HPTN 083 and 084 is to evaluate the safety and efficacy of Cabot Agave in men who have sex with men, transgender women, or cisgender women. And you'll see that this is a double-blind, double-dummy study. So it has two active products, Cabot Agave and TDF-FTC, because we want to see whether Cabot Agave performs as well as the standard of care PrEP product. To manage the concerns about an injectable, we have an oral run-in, and then you will see that step 3 is 48 weeks of TDF-FTC to cover this pharmacokinetic tail. And these trials both will follow participants up for up to 4 years, really, and the primary outcome that will be assessed will be HIV incidence occurring in the step 1 and step 2 period. So those studies are ongoing. They're being conducted, the African trial in women is being conducted in 20 sites in 7 countries in Africa, and there's one trial site in South Africa involving men. And the trials are both doing very well in terms of enrollment, with 083 about 85% enrolled and 084 about a third enrolled. But one of the challenges for these long-acting products is particularly the use of these products in women of reproductive potential. And some of you may have heard about the safety signal associated with dolutegravir that was announced by several regulatory authorities in May of last year. So what are the implications for our trial? And just to say that we have now required women to use long-acting contraceptives. We don't think there are drug interactions with these contraceptives, and we will target a very low pregnancy incidence. But for those women who do become pregnant, they are unblinded, and we refer them to care for early fetal assessments. And we will also do sub-studies to assess drug levels in these populations. So very quickly to round up, subcutaneous implants. The advantage of them is that you can insert them, but you can also remove them, and they're immediately reversible. They're longer lasting. They would have more consistent and predictable drug kinetics, and they have the potential to be used for multipurpose technologies, and then a number of molecules and devices in development. And finally, what the people are really beginning to talk about is the ability to produce multipurpose technologies. There are a number of options, actually, where these rings, injectables, implants are also being considered for co-formulation with contraceptives. So in conclusion, oral PrEP has been a vanguard product and it's set the bar very high for future PrEP products. To achieve global targets, we're really going to have to streamline and demedicalize our current programs and target them better. Long-acting products are really going to help us with some of the adherence challenges, but they won't help us with the health system and population issues. And ultimately, we hope that a range of PrEP choices and a range of prevention options will mean greater HIV protection overall. Thank you very much, and thanks to the people who contributed.